Hi friends, I'm Dr. P.K. Hazra, an interventional cardiologist working in AMRI and Apollo Clinic for last 30 years. So today I'll be speaking on hypertension diabetes with comorbidities. The management of hypertension in diabetic patients, there are different guidelines. Today I'll be speaking on RSSDI recommendations 2022. These RSSDI recommendations is very elegant and very innovative. Hypertension and diabetes mellitus are two of the leading lifestyle diseases in the Indian populations as well as South Indian populations that often coexist due to overlapping pathophysiological factors. Obesity, insulin resistance, inflammations, and oxidative stress are thought to be some common pathways. Up to 50% of hypertensive cases in India are diagnosed with type 2 diabetes mellitus. The recent RSSDI guidelines 2022 provide comprehensive recommendations for managing hypertension in patients with diabetes. As per the Indian guideline of hypertension, the hypertension is defined as systolic blood pressure more than 140 millimeter of blood pressure and diastolic blood pressure more than 90 millimeter of mercury. Primary hypertension is mostly asymptomatic, while secondary hypertension is due to various underlying pathophysiologies. Uncontrolled blood pressure, despite the usage of 3 antihypertensive drugs, is referred as resistant hypertension. Over 1 billion people suffer from hypertension globally, which is expected to rise up to 1.5 billion by 2025. Up to 50% of cases of hypertension are also diagnosed with type 2 diabetes mellitus. Hypertension presents as major risk factor for heart failure, CVD, CKD, PAD, end organ damage, and strokes. There is complex cause and effect relationship between hypertension and diabetes, which predisposes the patient to increased risk of cardiovascular complications. For patients with type 2 diabetes mellitus and hypertension, 24-hour ambulatory blood pressure monitoring is recommended to maintain BP targets of around 120 to 130 millimeter of mercury. The use of an aneroid sphygmomanometer must be preferred over digital devices. However, digital machines may be preferred for home-based blood pressure measurements. Blood pressure thresholds vary with age and comorbid conditions. Non-pharmacological managements of hypertension in diabetic patients are many. Lifestyle modifications may delay the need for pharmacotherapy, can complement the BP lowering effect of drugs. A low sodium diet, a physical activity, regular basis, and a healthy diet are recommended to manage hypertension in diabetic patients. So the management of hypertension starts with lifestyle modifications and the drug comes next. Pharmacological management of hypertension in diabetic patients have different types of combinations, permutations. ARBs are recommended as the first line of therapy because it doesn't cause cough, and it also protects the kidney in combinations with diuretic calcium channel blockers. And the complications rate of ARBs or the new way of treating hypertension like ARNI, where the ARB is an integral part, can give lifetime protection or hyperkalemia. For combination therapy, newer CCBs like cilnidipine along with ARBs are recommended. Cilnidipine is a very novel, effective, and safe calcium channel blocker, which is established for renoprotective benefits, albuminuria reductions. The combination therapy of ARBs with thiazide like diuretics also reduce the risk of renal disorders. While telmisartan can be the first-line ARB for treatment of diabetic hypertension due to its beneficial effect on clustering blood glucose insulin level, Alternatively, azilsartan with a similar safety and efficacy profile also recommended. So the profile of azilsartan is little different because it is a very long-acting and reduction of blood pressure is quite robust. Thiazide-like diuretics can be preferred in elderly patients with coexisting cardiovascular disease and heart failure. ACE inhibitors may be used as an alternative to ARBs for cardiovascular risk reduction, especially post-MI patients. Beta blockers like nebivolol, propranolol has been eradicated, I would say, for the treatment of hypertension. Atenolol has been eradicated, nebivolol and bisoprolol or metoprolol carbidopa with a previous history of cardiovascular disease and as an alternative to RAS blockade in pregnant women. So pregnant women like labetalol is a preferred choice. So beta blocker also plays a very significant role in patients with hypertension and tachycardia, especially in ER. To summarize, friends, hypertension is a strong modifiable risk factor for the macrovascular and microvascular complications of diabetes and hypertension. There is a very strong evidence from clinical trials. Meta-analysis supports targeting blood pressure reduction to at least 140/90, but lower is better without side effects. Lower blood pressure targets may be beneficial for selected patients with high cardiovascular disease if they can be achieved without undue burden and side effects. Such lower targets may be considered on an individual basis, case to case. In addition to lifestyle modification, multiple medication classes are often needed to attain blood pressure goals. If 3 drugs or 4 drugs fails, then there is a new therapy called renal denervations or RDN. So sometimes some people may need only 1 drug, some people may need more than 1 drug, some people may need 4 drugs plus renal denervation to reduce the burden of antihypertensive drug. So hypertension therapy or polypharmacy has evolved over many decades for betterment with lesser side effects, better adoptions, and better acceptance by the physicians and the doctors. So hypertension can kill you, but there are so much of development in the field of polypharmacy and antihypertensive therapy. Hypertension doesn't kill the way it used to kill in the past. So stroke, heart failure, and cardiovascular disease and arrhythmia reduction can be done with a combination of therapy. So stay tuned for the future direction from me. For the time being, I'm signing off. And thank you very much for your kind attention. Have a good day. Thank you.